Greeks invented it, but they got their name, you know, between the Greeks and the Latins. The Greeks probably have more input into medical nomenclature than anybody else. So the word is broken down, ana, which means without or against, and phylaxis, protection. So without protection is what it generally refers to, the general definition for anaphylaxis. And again, it's been described since ancient times, just nobody knew what it was. He died. He choked and died and stuff. Yeah. Characteristics, but nobody knew the mechanisms or had any idea. Until the early 1900s, these two French guys, French were experimenting with dogs. And they were doing immunizations, trying to challenge these dogs with a variety of vaccines. And a number of them, after repeated immunizations, had fatal events that all had similar characteristics that involved hypotension, respiratory distress, and airway disease, angioedema. And again, nobody knew what it was because nobody had worked out the chemistry, the biochemistry, the anatomy, microscopy that goes into describing what's happening at a cellular level. But they knew that there was a cause and effect, that there was something in the environment that triggered a response that was disproportionate. And when you think about it, you know, why? I don't have the answer to this. Maybe somebody has. What's the purpose of anaphylaxis? What purpose does it serve for the organism, the individual? Protect it. It doesn't, right? It's harmful. So why does it even exist? Why does it happen? Why would we have a system that causes us to self-destruct?
So we don't self-destruct our own selves?
Is that like a double negative?
What? Did I say that out loud?
Yeah, and you know, and nobody knows. I mean, it's one of those things that, you know, there's our immune system is primarily designed to protect us from external agents. Okay, usually bacteria, viruses, infectious agents, but also harmful chemicals and substances. But in the process of doing that, there are different aspects of the immune system. And sometimes the immune system fails to distinguish something that's external from something that's internal. And so rather than attacking that external source, there are similarities or there's crossover between proteins that are part of our own makeup. And the immune system is activated to attack those proteins. They're going to cause serious disease. Common diseases that describe this are the autoimmune diseases. Okay, so things like rheumatoid arthritis and lupus, those are autoimmune diseases. And that's the situation, again, when antibodies are produced against normal cells and tissue. With anaphylaxis, and I'll go through the mechanism a little bit later, the origin is felt probably that this system was designed to help to contain and neutralize parasites. We still have we don't see a lot of parasitic infections in our culture, but around the world there are still a lot of worms and parasitic infections. And this part of the immune system actually, because a lot of the byproducts, the cells that fight these organisms are present in the mucosal surface of the body. So the gastrointestinal system, the airway, the lungs, the mucosal barriers. And that's usually the way parasites enter the system. Well, somehow Mother Nature in its wisdom got a little screwed up and created a certain set of antibodies that do more damage to the host than to the organism that's attacking. And that's the subject of anaphylaxis. So in most instances, anaphylaxis isn't due to an infection. It's usually due to a substance in the environment that triggers this immune response. Who's ever had, anybody here ever have an anaphylactic reaction? How was it? best.
That's what's the matter with you?
So, yeah, so you have
Yeah, wasps, it's horrible.
angioedema,
Yeah.
airway problems,
Covered in hives.
covered in hives.
breathing difficulty.
So there's a spectrum, okay? But, you know, in all populations, there's a 1 to 2% lifetime risk that at some point, I mean, who has never gotten hives in this room?
Who has
Never
never?
had hives? Oh, you do.
They're
No, I mean, at some point in your life, chances are that you'll have some sort of reaction. It's not always allergic, but the response, the allergic response, the release of histamine is something that is not always just mediated by an allergen, but it can be triggered by other things, stress. In my case, I've had hives at some point in my life for like a year. I had these huge welts over pressure points on the soles of my feet, at the belt line. Couldn't figure it out. Nobody could figure it out. Eventually, it just went away. But again, there are various things that will cause, that stimulate those cells to release histamine, which is one of the mediators. The rates are increasing in affluent groups. Well, why is that?
So the hygiene theory, that you're not supposed to.
Right, exactly. That's bound to be part of it, the hygiene theory. So, you know, by the time you reach the age of, 10 or 12, if you haven't eaten a pound of dirt, you're probably, not going to make it. The idea is, having exposure at some level. Obviously not, extreme exposure if you're highly allergic, but in groups of populations, the cleaner, the more hygienic, the more likely to have allergic reactions. Risk factors for anaphylaxis: people who are predisposed naturally, people who have asthma, obviously. Atopy is a condition that refers to the hyperallergenic state, people who have eczema, who have asthma. Oftentimes these are people who are fair-skinned, light-colored, redheads, freckled people. A lot of times if you scratch them on the surface of the skin, you'll get a wheal response. They're just loaded with mast cells. They're just, waiting to discharge those mediators. Doesn't mean that they're going to have an allergic reaction, but they have the equipment. They're already they're locked and loaded. And then medications. And I listed these two, beta blockers and ACE inhibitors, not because they necessarily cause allergic reactions, but they can aggravate or make allergic reactions more difficult to treat. Beta blockers, now why would beta blockers be a problem in somebody who's having an allergic reaction? Right. One of the things we use to treat it, obviously, epinephrine is not going to work as effectively in people who are on beta blockers. They're also, because,
Would they also, in theory, say for a bee sting or any peanut allergy, would they also be beneficial in not, in keeping your heart rate lower and not spreading it?
well, yes and no. I mean, the beta stimulation is actually a helpful thing for bronchial smooth muscle bronchospasm. So if you're blocking the people who have a predisposition to asthma, a lot of those people shouldn't be on beta blockers to begin with, because they're more likely to wheeze just because they don't have as much of their natural, their endogenous catecholamines to keep their airways open. So if you challenge them with yet something else, then they're going to be that much more blocked.
Dr. Penney, so in an anaphylactic reaction, would the beta blocker, obviously there's hypotension associated with the anaphylaxis. Would the beta blocker have an effect on that? Would it potentiate it?
It would potentiate it, yeah. And it might make it more difficult to treat. You might be less sensitive to epinephrine, so you may require more doses. What else can you do to mitigate that, or to overcome that if you don't have a good response to epinephrine? Are there other drugs?
Is glucagon?
Glucagon. Okay, that's a way of treating the adrenergic system without directly stimulating the catecholamines. But that's getting a little bit into treatment. ACE inhibitors, Has anybody ever seen a reaction to an ACE inhibitor?
They get big lips.
That's fine.
Pretty scary.
Yeah.
Probably one of the scariest. And it's not anaphylaxis in the true sense. It tends to be very localized. It tends to involve the airway, which kind of sucks. Especially the lips, the tongue, and it's very difficult to treat. It's very refractory. It's not as gratifying or satisfying to treat as somebody who has an acute allergic reaction with hives to, say, a peanut allergy or a bee sting. Because you give them something, you give them epinephrine, you give them steroids, and nothing happens. What you hope is that they don't get worse. But they tend not to respond as quickly. So they're sort of in a category of their own.
Now, why is it isolated to just that area?
Well, they can cause reactions everywhere. I mean, it can affect any of the mucosal tissues, but it tends to be more prominent in the mucosa of the oral pharynx, but anywhere in the airway. These people will wheeze. And why not the skin and why not? I don't know. Good question. Yeah. But it's not a truly allergic. It's not an allergen-induced thing. It's releasing mediators, and there's other mediators besides histamine that cause angioedema. So it's not necessarily directly. It's actually more related to another mediator called bradykinin, but that's another subject. Malignancies. There are a lot of malignancies that can be associated with allergic reactions, with anaphylactic reactions. People with various kinds of leukemias are more prone, again, because of this immune dysregulation that they have. And then rare genetic disorders is a condition called mastocytosis. The mast cells are the mast cells that contain histamine. People who have an overabundance of this can have anaphylactic-like reactions. The basic classification that we use medically is it, does it matter in terms of the treatment? No. But it's helpful so that you don't, that you learn to recognize it. There are immunologic causes, and that's where, again, there's a specific food or substance or venom or drug that reacts with an antibody, which is, in this case, is IgE, which then triggers release of histamine by mast cells, which are present in the tissues. And the mast cell equivalents in the bloodstream are called basophils. They have the same properties that mast cells do. So in the mast cells, when they're released in the tissues, you get the hives, you get the angioedema. When you get release of the precursors of these chemicals in the bloodstream, you get the systemic effects, the hypotension, the shock, the more systemic symptoms. The non-immunologic triggers, the so-called anaphylactoid, are due to direct interactions of a trigger. So heat, cold, pressure, like I mentioned, people who sometimes have pressure hives or angioedema. But it can be a full-blown anaphylactic reaction. So heat and cold, people who exert themselves, who are exercising, will sometimes develop an anaphylactic type of reaction. And then the reaction that occurs to IV contrast and opiates. Okay? One of the problems, one of the concerns with morphine, with the opiates, is that they sometimes will produce a burst or release of histamine. And it's not, again, it's more of a direct drug effect, similarly to what happens with people when they get IV contrast and they get an anaphylactic reaction. Again, does it matter in terms of the treatment? No, because the signs and symptoms are the same, but it helps you to sort of not overlook the causes. When you see somebody with an anaphylactic reaction and there's no apparent cause, they weren't eating peanut butter, they didn't have a bee sting, they're not on a drug, and so you wonder, well, could this still be anaphylaxis? Yeah, it can still be anaphylaxis.